Some people in the room here have helped me along the way. I really appreciate it. It's an honor to be up here, actually, because I look out and who's talked before me and to say, wow, what an honor. And so thank you again for the invitation. So my title is Integrating PI3 Kinase into the Treatment of NHL, and maybe the title should be Reintegration, because this is a long story. In fact, the first drug that I got to work with at Memorial as a fellow was Cal 101, back in the first patients on CLL, and sometimes it's fun to tell those stories. But here are my disclosures, and my objectives today is to explain the class 1 isoforms of PI3 kinase and match them through respective drugs to the isoforms inhibited, discuss emerging results and adverse event profiles between differing PI3 kinase inhibitors and follicular lymphoma, and I'll delve into CLL, SLL, discuss how to integrate novel drug combinations within clinical trials, and discuss paradigms in the management of common PI3 kinase inhibitor adverse events. And so with that, I'll lead off, and this is my only cartoon. But PI3 kinase physiologic function is 3 different classes. The class of relevance for today's discussion is the class 1 and the class 1A and 1B. As you can see here, the P110 alpha, beta, and delta inhibitors are all class 1, and the P110 gamma is a class 1B. Now, these isoforms have different functions in the body. Alpha is intricate in insulin signaling, and we'll kind of go through how that can affect when you try to inhibit the alpha isoform. Betas can be involved in platelet function. Delta is involved in B cell survival and signaling. And then gamma is involved in T cell function and potentially neutrophil and maybe some microenvironment work. So with this, I'd like to kind of start off by playing a little game of match. My 3-year-old and I, this is quite frequently something that we play. But over on the left-hand side are some PI3 kinase inhibitors, and I put them in alphabetical order and color-coded to be, if you will, fair and balanced, so that trying to not favor one over the other, but to give kind of an approach throughout this talk. And so there are some new PI3 kinase inhibitors up here, and then there are some older PI3 kinase inhibitors, and some that may not be further developed in lymphoma. So to start off with that, buparsolib is a pan isoform inhibitor where it gets alpha, beta, delta, and gamma as part of it, whereas copanlisib is an alpha delta inhibitor. Now there's going to be a theme here. Duvelisib is a delta gamma inhibitor. Idelsole inhibits delta. ME401, if you will, the new kid on the block, goes after delta. And umbralisib, formerly known as TGR-1202 with Dr. Bartlett's slide, does inhibit delta also, but it is reported to inhibit CK1 epsilon, and I think that story has further chapters to go, but it is kind of an interesting story that's starting off. And so with that, I'm going to, was given the task of talking about non-Hodgkin's lymphoma, which is a very broad topic, but I chose to cone it down to discuss not only results within CLL, SLL, but also within follicular lymphoma with these individual drugs. So the first drug that we're going to talk about is buparsolib, and I was saying that this was a pan PI3 kinase inhibitor. It is an oral drug given once a day, so we're going to see some different oral or routes of administration, but also some frequencies. You can see here it was studied not only in follicular lymphoma and in CLL, but in this population it was fairly less heavily pretreated compared to some of the other drugs, where it had an overall response rate of 25% in follicular lymphoma and 46% in CLL, SLL. You're going to see a common theme in CLL, SLL with these drugs is that there is a very high partial remission rate, but it struggles to obtain complete remissions, and I think that is something that is across the field in CLL, SLL based upon the response criteria often. So the PFS was 9.8 months, and the duration of remission in this drug was 3.5 months. I tried to keep the slides the same for each drug so that there can be some gentle cross comparison Obviously, there's been no study to date that has looked at PI3 kinase inhibitors head to head. So be careful when you do this, but I don't know any better way to kind of help educate you all. So the AE profile over here, hypertension, hyperglycemia. Hypertension was not looked at. Remember, this will engage the alpha isoform, and we'll go into that. Hyperglycemia was seen, so kind of noting that this does, I think, is a pan inhibitor that is hitting alpha. The ones I want to focus on are diarrhea, colitis, and ALT elevation as we go through this. Diarrhea seems to be, if you will, a class effect. For the majority of the drugs, you're going to see low grade, grade 1, grade 2, but I can tell you from Nebraska, where most of my patients travel down Interstate 80 at some point, grade 2 diarrhea, they do know where the rest stops are on the interstate. Okay, they may take a Imodium before they leave home to try and, in some ways, make it to clinic. And then the last one, because I'm going to talk about some novel combinations I think we pay attention to is fatigue. Because grade 1, 2 fatigue, if it's additive, if you see two drugs that have 30% fatigue rates, grade 1, 2, what will that fatigue be when you combine the drugs? So moving on to capanelisib, the mechanism of action again is an alpha delta inhibitor. This drug is FDA approved. The route has changed here. So this is an IV drug given at 60 milligrams, given on days 1, 8, and 15 of a 28-day cycle. It has been studied more extensively in follicular lymphoma where it has its FDA indication, but it also has been studied in CLL, SLL as a single agent. Here, as part of the approval, the treatment median number of treatments was 3 with a broad range. Did have a high overall response rate at 59% and did see some complete remissions. The PFS was 11.2 months and duration of response was 12.2 months. Again, less experience in CLL, SLL, and again, no response, no complete responses. Here, because of targeting off target, I would say, is hitting the alpha, there was reported hyperglycemia, grade 1, 2, 9%, grade 3, 4, 41%, and hypertension was also seen with this drug, likely an alpha consequence. They did report out at ASCO this year their experience with type 2 and type 1 diabetics, showing that you can still get the drug into that patient population and there can be responses seen. Going across the diarrhea, colitis, ALT, this drug did have lower grade 1, grade 2 profiles from these GI-related effects. Moving to duvelisib, or formerly known as IPN-145, again, another drug that I got to experience in the early days of fellowship. This is a delta gamma inhibitor, so now we're engaging that class 1B G-coupled activation rather than a tyrosine kinase activation with the 1A classes. This is an oral drug given at 25 milligrams twice a day. The little flip side here is this drug has more experience in CLL, SLL than follicular lymphoma. However, in the follicular lymphoma population, I think that this is where you try to make your notes, is that when this drug was studied, this was studied in a double refractory population. So again, this is where it's very difficult to compare across classes, because if you just blindly look at the overall response rate and not, the devil's always in the methods of these studies, you can often say, well, that drug may not be as active as the other drug, but understanding the patient population is very important. And so the overall response rate in follicular lymphoma was 41% with 0 complete remissions, but a PFS of 8.3 months and a duration of remission of 9.2 months. Where in CLL, the overall response rate was 73% and 1% CRs, and this was taken from the most recent reported DUO study where it was compared against ofatumumab, but this did not include the crossover data. So this drug did not report hypertension or hyperglycemia. I think at the time, the alpha effects may not have been known. The diarrhea, colitis, and ALT events, diarrhea, all grades, came into 44%, but again, majority within this class remained low grade. Neutropenia was one of the key things that I think as we talk about, can we get to novel combinations, grade 3-4 neutropenia was seen at 23%. And another interesting AEs is there was some PJP, CMV, and fungal infection seen, and there have been this kind of experience in some other drugs across the class. I caution on the CMV because this is a heavily pretreated population. It is not common for us to check a viral load at the time of initiation of therapy to know if those were low-level CMV reactivate or low-level CMV activity, and then treatment was just found as part of a workup for, if you will, for diarrhea. Idelalisib is a pure delta inhibitor. Again, it is FDA approved. It is given orally at 150 milligrams BID. There is experience, I think a sizable experience in both follicular lymphoma and CLL. In this experience, the Idela was given for CLL, SLL with rituximab, whereas follicular lymphoma was single agent. 72 patients were treated in the follicular lymphoma arm. I would argue that this is a heavily pre-treated patient population, and if you really, again, dig into the details of this study, this was a poor risk population. They really, I think, did a good job in this population. Not only were they double refractory, but they had some very low creatinine clearances, which in other clinical trials, they would have likely have been excluded. So commending them as a first in class, if you will, drug, going through that time to really tackle that population, I think was important, because we all know drugs can get approved, but then we go to try to use them, and we realize that the majority of our patients may not have been eligible for the clinical trials, but gee, we still do we have other options for those individuals, and sometimes it can be trying when it's the first time that you're using these drugs. So the overall response rate in follicular lymphoma was 56% with 14% CRs. The PFS was 11 months, and the duration of remission was 11 months. In CLL, overall response rate was 81%, but again, zero CRs. I could not find the PFS was not reported in the manuscript. I couldn't find that it was updated. I imagine it has, because this is such an this publication was from 2014, so I've been digging for that, and maybe I need to email Dr. Gopal. So the adverse events of interest in the follicular lymphoma cohort, again, hypertension, hyperglycemia was not reported, just I think because we hadn't had experience with different classes of the PI3 kinase inhibitors. However, diarrhea, 43%, again, the majority low grade, but ALT elevation was seen in 47%, and really a management strategy that we'll go through later really became kind of part of this class. And how do you manage some of the adverse events of this drug if you're expecting to get derived benefit and keep people on long enough to derive benefit? And that white paper was, Dr. Zellens, I know you contributed to that white paper by Dr. Coutre. ME401 is arguably the new kid on the block. I know that there are other PI3 kinase inhibitors, but I wanted to point this one out specifically because I think the activity is very interesting, and they're going to have the ability to use the experience of other PI3 kinase delta inhibitors, I think, to help develop their drug. And so it's a delta-specific PI3 kinase inhibitor. It is oral. And it is, right now, they tested ranges from 60 to 180 milligrams given daily. But because of the activity at a lower dose, the 60 milligrams dose is, I believe, what is going to move forward in further testing. Again, small numbers in follicular lymphoma. The median prior therapies is 2 with a range of 1 to 5. The overall response rate in follicular lymphoma is 86%, but there are some CRs at 21%. Because of small numbers, PFS and duration of remission was not reported in their ASCO abstract. So in the CLL, there was 9 patients. Again, overall response rate was 100%. And I'll clarify this CR, right? These were, I believe, nodal PET negative responses in this population. And Dr. Zellens, you can correct me if that's wrong, but that's my understanding of that. So interesting with this drug, AST/ALT elevation was seen in 45% of the individuals, but again, low grade at 39%, and neutropenia at low grade 32%, but 13% grade 3/4 neutropenia. The interesting AE with this drug is there was some late onset rash that will need to be further monitored as the drug, if you will, grows up. And the last drug I want to talk about is umbralisib. This is a delta PI3 kinase inhibitor. Again, this does have some through work done by Dr. O'Connor. Potentially inhibits another moiety called CK1 epsilon, which has a very interesting story in itself. This drug is also given orally. When it was studied as a single agent, it was dose escalated between 50 to 1800 milligrams. There was a very complicated dose ramp-up phase as the drug was micronized kind of in the middle of the study. So this is broad-ranging data that we're reporting. It is given, or that I'm reporting, it's given daily. The reason why I think this drug only has 17 patients in follicular lymphoma and 20 patients in CLL is this was a big study, but this was paired with another monoclonal antibody, ublituximab, and kind of studied in a more, at the phase 2 dose that was moved forward more extensively. So the overall response rate as a single agent in follicular lymphoma was 53%, where it was 35% in a limited CLL population. The CR rate was 12% in follicular lymphoma. The interesting thing here to pull out is the AE profile of the 90 patients treated, again, in a dose escalation study, was the diarrhea, yes, was seen there. And so diarrhea is becoming a common theme where you see 30 to 40% grade 1, 2 diarrhea in the class. The colitis, there was only 2% grade 3, 4 colitis. AST/ALT total 7%, and fatigue 28% grade 1, 2, and grade 3, 4, 3%. So I just ran through a long laundry list of follicular lymphoma, CLL, SLL, and the AE profiles, but really I think where you're going to see the field going or in reintegrating this class specifically into CLL, follicular lymphoma, and also some of the unmet medical needs which align with diffuse large B-cell lymphoma, especially in those people who are too sick to CAR or can't get CAR T cells with diffuse large B-cell lymphoma or elderly DLBCL is this, pairability. So is this a class that can be paired together with other novel agents? And I think the novel generation is among us. And I would appreciate, this was a late night clinicaltrials.gov as well as PubMed search, trying to be as accurate as I can across the 6 PI3 kinase inhibitors that I talked about, but where in clinical trials are they going? And so buparsolib, as we talked, has been studied with a CD20 as well as a BTK, ibrutinib, that's been reported by Dr. Batlevy from Memorial. Capanelisib has been studied and is being studied with CHOP as well as the CD20 and bendamustine in an ongoing trial. Duvelisib has been tried with CD20 monoclonal antibodies, bendamustine, a PI3 kinase inhibitor with bortezomib, and HDAC with romidepsin. I will call out a colleague and a friend, Dr. Alice Moskowitz, is running this study at Memorial, and I think that this was one of the dark horse oral presentations at last ASH. If you take the duvelisib AE profile and then look at the HDAC arm, it seems to me there may be some reduction in the AE profile in the combination of HDACs, and I think and I hope that they're going to tease this out even further, because I think that this could be something very important for this class if we can get some of those GI side effects, those immune-mediated T-cell side effects to be dampened. Idelalisib has been looked at with CD20s, bendamustine. Those are red X's with SICK and with IMiDs because this is where some toxicities were seen and I think slowed down some of the pairability or some of the enthusiasm in this class to pair them. SICK with intisplitinib, which had some pneumonitis risk, as well as lenalidomide, where there was some sepsis-like syndrome seen, which shut down studies very early. And then umbralisib, there are several X's, and I believe that's why there's such little single agent data, as this drug really has, I think, used its AE profile to argue that it can be used across many different classes, and a lot of these studies are ongoing. So in the last minute here, I'm going to try and go through some treatment discontinuation. So this is a very early paper by William, kind of looking back in the IDELA days. Standard group would be the PI3 kinase inhibitor plus an antibody versus the novel group, which was a PI3 kinase inhibitor plus another class. And this data showed that perhaps there was some increased pneumonitis in the novel group. But again, I caution because this included the intisplitinib experience. But at least in the novel group, there was no increase in diarrhea, colitis, or LFTs outside of what was reported with a single agent. So while this data can be taken to have caution with novels, I think that there can be some re-energizing of the novel using PI3 kinase inhibitor with the data that we hope to produce. And the last two slides, these are both from the Couture white paper, kind of talking about management of grade 2 and grade 3-4 diarrhea. I think that it has become kind of, if you're using this class, this is something that you're paying attention to and common. And I caution that colitis, in my opinion, is a pathologic diagnosis. Diarrhea is what is the patient's reporting to you volumetrically, so how many stools are going a day and how much. And so diarrhea, colitis, grade 3-4 diarrhea, is that really colitis or is it grade 3-4 diarrhea? And I think that that's something that it can be better investigated in the clinical trials that are ongoing with PI3 kinase. And then elevated LFTs, and this comes again out of the idelalisib experience, but has been basically in some ways boilerplated into further PI3 kinase inhibitor studies using the knowledge that was learned from PI3 kinase. And lastly, last slide, other adverse events. And so there is with the experience with capanlisib, with hyperglycemia and hypertension, I think it's important to know how to move forward if alpha is going to be inhibited, to try and allow patients to stay on these drugs for a longer period of time, limiting dose interruptions or dose reductions here. So with that, I leave the conclusion slide blank because over 7 years I've talked about PI3 kinase inhibitors, and early on the conclusions were different, and I think now we have several drugs in the class which have interesting adverse event profiles, which may allow them to be used in novel combinations moving forward. I try to use a triplet analogy in HIV. Sometimes you need multiple drugs to hit different things, and if you can, it may not be the first-in-class drug that gets you to the finish line. So trying to pair things that have similar AE or differentiating AE profiles that are not going to be hopefully additive, that can target a population that's an unmet medical need, and I still think there are several of those in non-Hodgkin's lymphoma. So with that, I'll end. Thank you.
Is going to lead our discussion. Thank you all. We especially appreciate the members in the audience who contributed some slides. And we're going to do some example cases as time allows. We're also giving the people who provided the slides a chance to present their own case. Just texted Jake Summarize. And we'll do a few of these as we're developing, and there may be some questions that come up about the talks too, but most of the time